Good evening, everyone, and welcome to the Health and Adult Social Care Overview and Scrutiny Committee, 29th of November. Joe, would you like to read out the housekeeping notice, please?
Yes, thank you, Chairman. So please note that this meeting is being recorded by the Council for live broadcast and will be published on the Council website for a minimum of 6 months. Please could everyone present follow these ground rules. Only speak when invited to by the Chair. For those present in the meeting room, please use the microphones on your desk when speaking. If accessing the meeting via Microsoft Teams, please turn on your video function before speaking. Again, if you are accessing via Teams and would like to speak on an item, please do so by using the Raise Your Hand feature in the bar at the top of the Teams window. For those in the room, please note that if the fire alarm sounds, you must exit the building by way of the nearest available signed fire exit route and make your way to the ground floor of the multi-storey car park. Finally, please ensure background noise is kept to a minimum and that mobile phones and other devices are turned off or switched to silent for the duration of the meeting. Thank you, Chair.
Thank you, Joe. We have several members joining us remotely, and that's Councillor Andy Jones, Councillor Roberta Rocker and Councillor Susan Phillips. And hopefully we've got Louise Bate here on the call. We've got portfolio holders Mohan Iyengar and Councillor Lawrence Fear, lead member for Wellbeing. And officers present, we have Phil Hornsby, Director of Commissioning for People, David Vitti, Director of Adult Social Care Services, Betty Butlin, Director of Operations for Adult Social Care. And then joining us online will be Elizabeth Saunders, Interim Director for Adult Social Care Commissioning, Emma Senior, Commissioning Manager, Prevention and Wellbeing, Mark Harris, Head of Service, Mental Health and Learning Disabilities, Dorset CCG, Sam Crow, Director of Public Health, Dorset. And in the room we have our Democratic and Overview and Scrutiny Clerk, Joe Tyler. Joe, have we got any apologies for this meeting?
Thank you, Chair. Yes, we have received apologies from Councillor Kieran Wilson for this meeting, and subsequently with item 2, Chair, substitute members, we have Councillor Chris Rigby substituting for Councillor Kieran Wilson. Thank you.
Thank you. Have we any declarations of interest? Councillor Matthews.
Thank you, Chair. Yeah, a couple really just for transparency purposes. Item 7 on the agenda, BCP Carers Strategy. I'm a carer, so that's the first one. But the second one, the Dementia Services Review, again, just for transparency purposes, my wife works for the Alzheimer's Society and it is mentioned in the report. So those are the two. Thank you.
Councillor Evans.
Thank you, Chair. Yes, just for transparency, I'm a bank employee of University Hospitals Dorset.
Thank you. And Councillor Johnson.
Thank you. And the same with me. I'm employed by University Hospital Dorset.
Thank you. Confirmation of minutes. Does the committee agree to confirm the minutes of the meeting held on the 27th of September as an accurate report? Thank you. Can I just mention at this stage we will be swapping agenda items 8 and 9 due to Mark Harris not being able to join us till a bit later on. But let's move on to agenda item 6, the action sheet. Oh, I'm sorry. I haven't got number 5.
Chair, just confirm that with item 5, public issues, there are none for this meeting. Thank you.
Thank you, Joe. Item 6, action sheet. Is the committee happy to agree the action sheet which tracks the decisions, actions and outcomes arising from previous committee meetings? Councillor Evans.
Just to say, the first item on the action sheet, the Dorset ICS, I don't think it is on our future plan at the moment, so might need adding.
Thank you, Councillor Evans. Anybody else? No. We move on to agenda item 7, the BCP BCP Carers Strategy. And can I ask David Vitti and Emma Senior to introduce and present this item? Thank you.
Hi, I'm Emma Senior. So our report provides an update on the BCP Carers Strategy. We're currently undertaking a review of all of our carers services in collaboration with carers and key stakeholders, and this will inform our new strategy. We've also held 2 informal engagement sessions with members of this committee and will arrange more as the review progresses. We're currently in the process of reviewing and refreshing a pan-Dorset strategic vision for carers, and we're working on this with statutory partners across Dorset. The creation of the BCP strategy will run alongside this work and reflect the specific challenges that carers face within our area. We know that at least 11% of people across Dorset are unpaid carers, and one of the challenges is identifying them. We've already started to engage with carers in a number of different ways. These are all detailed in the report, but include workshops, surveys, meetings with the BCP Carers Reference Group and the Pan Dorset Carers Steering Group, and in-person events. We held an event at Kinson Community Centre just last week for Carers Rights Day, and it was great that we had 3 councillors attend that event, and we've had really positive feedback from carers about the day as well. We've recently completed a new survey, which is ready to be sent out to all carers on our information service. At the last informal engagement session with members, you asked to see a copy of that survey before we sent it out. So I've sent that to Joe Tyler for distribution, and so hopefully once you've received that, if you've got any comments, please let me know. And so the recommendations from the report were for the committee to consider and scrutinise its contents, to consider attendance at future engagement sessions, and to request an update at future committee meetings. So if you'd like to make any comments about the report, or if you have any questions, please let me know.
Thank you, Emma. Got any questions? Thank you, Councillor.
Thank you. Thanks, Emma. Me. My question, as I've asked before, is how do you identify people? Like you said, there's about 11% that you're not identifying. How do you find them? How do you find the carers?
Well, that is our biggest challenge, and that's something we're working on with our Pan Dorset partners. So we're working with the NHS, with GP surgeries. We want to come together and agree a way to identify carers. A lot of people don't even realise that they are a carer. They don't recognise themselves as such. And some people have said to us they don't actually like the word carer, that they don't feel like a carer. They're a partner, they're a husband, they're a wife. So that is one of the things that we know is a challenge. But it's something that we're going to work on with carers themselves and with our strategic partners as well, to try and help us to think about how we can do things differently and how we can try and identify those carers that we know are out there, but we don't know who they are as yet.
Thank you.
Thank you. Councillor Evans.
Thank you. Moving on from that, you mentioned people who don't always recognise themselves as carers. I wondered if, as part of the survey, we're going to look at a better term for the carers. We've, in the recent paper we've been using, used to be informal carer, which I wasn't very happy with, and it's now just changed to unpaid carer, which seems to value the person even less. I was just wondering if we are looking at alternatives and what's being suggested.
Yes, definitely. We certainly will be asking carers what they think, what terms they would like to use. We've recently actually spoken to a group of people about that very topic, and what you find is when you say the word carers, that they often do think of paid carers, of care workers, and like you say, unpaid carers also confuses people, because sometimes they think, well, if I get carers allowance or attendance allowance, does that exclude me? So we do need to think of something, and yeah, I agree that we should be including that, and part of one of our surveys we should be asking carers, and we'll ask at our reference group and the steering group as well if there is another term that they would prefer.
Okay. Emma, can I ask, on page 22, number 6 of part of the local provision, It said 38.10% of BCP carers were receiving self-directed support in 2020-21 compared to 84.1% in the South West and 86.9% in England. Why such a huge disparity in the numbers? Do you know why?
Well, I think part of it is the way that we record our figures, and it's something that that I'm going to be looking at with our management information team, because we're not sure yet that if it's the case that in other areas of the Southwest, they actually record different things for self-directed support than we do. And because we've got the two different case management systems at the moment, we've got both Care Director and Mosaic. We need to look into how we're reporting self-directed support on both of those systems and compare that with other places in the Southwest as well. That would be our first starting point, is to see, are we recording differently? Because we certainly do provide a lot of different ways of supporting carers, and I think sometimes some of those just aren't recorded in those ways, and they don't come up on those figures. So that is something that, as part of a key focus area on the report, that we'll be looking at.
Okay, thank you, because it is such a huge gap, isn't it?
Yeah,
it just sort of didn't seem right to me that that was that. Sorry, David.
Chair, if I can just add to that, it's true that locally we commission a lot of services on behalf of carers. So, for example, the sitting service, whereby a carer will receive some support at home for the person they care for so they can go out, we commission that for individuals. In some authorities, they would pass a direct payment to the individual so they could buy that sitting service themselves. So the outcome's no different. The individual receives a sitting service. Previously, our carers have told us they've liked us to commission it for them. So part of this carer strategy work will be to go back to carers now, several years later, and ask them whether they in fact would like to commission this care themselves, which would increase the number of people receiving self-directed support, or whether actually they would like us to carry on doing it for them as a council, which would lower the amount of people with self-directed support. So it's not necessarily a good or a bad thing, it just reflects how carers in a locality receive their services.
Thank you. Emma, can I ask, on page 55 of your report, it says the age range. Now, can you tell me, is that the age range of the carers or the age range of the people they're caring for? I mean, you've got 38% are 71 to 80 years, 25% are 81 to 90. I mean, if they're carers, it's a great age, and really, it's possibly a little bit too much for people of that age. So I just wondered if it was those people being cared for were 71 to 80, or whether it's their actual carers.
It's the carers themselves, and you're right. We have a lot of carers that are between the ages of 71 to 80. I mean, carers span from the age of 18 plus, really. But like you say, we've got a lot of carers who may need support themselves, and it's actually getting very difficult for them to care for their cared for person at that age.
Okay, thank you. Anybody else got any questions? Councillor Butler.
Yes, I notice you say you're looking at valuing carers in Dorset as the Pan Dorset vision. I'm a bit confused as to why we can't work with Dorset as a whole, because they've got towns as well as we have. They've got Weymouth, Gillingham, and other towns, that are quite big. So they're not a lot different to us, Bournemouth, Christchurch, Poole, really. So I just wondered why we're sort of doubling up on what's come out of the previous survey.
Well, we're working really closely with Dorset, but we felt that as two different councils, we do have a different client base. We've got some very urban areas in comparison to some of Dorset's very rural areas, and we do jointly commission some of our carers services with Dorset, but there are some services that we do separately, and there's It's interesting, actually. One of the services that that we currently commission jointly, a lot of carers in the BCP area are taking that service up, and a lot of carers in Dorset aren't, and we're looking at reviewing that. So there are some differences with carers and what services they want in the different areas. So although we're working really closely with Dorset, we felt that for BCP and for our residents, we also want to have a separate strategy as well.
Thank you.
Phil.
Thanks, Chair. Just to add what Emma said, yeah, it's quite right. This is the Pandorsa work is a vision. So it's a vision statement, a set of statements that say what we would want for carers and what carers would want for themselves and their loved ones and cared for person. So what we're doing is taking that high level vision and then interpreting that into our own strategy with the input from people from across BCP, including elected members, of course, so that we frame exactly what it is that we want and how we want to give it, not just being tied into a much wider thing, which may or may not meet the needs of our carers, but where it's right and proper to work together, where we can clearly identify that we want the same thing, and I say we, I'm talking about carers, then we'll do that jointly. We'll reserve the right to meet our own local needs in our own local way, and that's appropriate, I believe.
Thank you. Councillor Jones.
Yeah, thank you, Chair. I'm just going to connect question 10 on page 52, where one of the stats says that 22% of people were dissatisfied or very dissatisfied with the support they receive from their GP as a carer. Do we know what those reasons are, and how does that compare with other areas? Is that a sort of figure you'd expect to see?
I don't know those reasons specifically, but we do know that we do need to liaise with our GP surgeries more, because that's where a lot of carers go for support. It's where we could capture carers, and that's where that whole identification of carers matter comes in, because a lot of people will go to their GP surgeries, and if they can register there as a carer, it opens up to a lot of services that are available. So as part of the Pandorset steering group, we do meet with the NHS and the local CCGs, and that's where we're going to link in better with GP surgeries. So although I don't know the specific reasons, we didn't capture them in that particular survey, we do know that we need to improve that, and we'll be working with partners to do so.
Thank you, Emma.
Councillor Matthews, did you have a question?
Yeah, it was just a really quick one. Thank you, Chair. I was just looking at the kind of age profile that Councillor Edwards mentioned. I'm kind of looking at the other end of the spectrum. So I've realised that this is geared towards post 18-year-olds and stuff. But the point I would like to ask is, it does mention on the report that the kinds of this strategy is going to feed into how young carers are sort of supported and stuff. But I'm kind of thinking it's a two-way process, because surely we should be kind of getting that kind of input at this stage as well. Because certainly some years ago, when I was involved in a carers working group, and we went out to Poole High School and spoke to some young carers, and their experiences were very, very similar to people who could be in their 40s, 50s, 60s, 70s. The difference being that these youngsters were doing it before they're going to school in the mornings. And so it really is, I really would like to see some sort of linkage with that. But the other thing as well, in terms of the returns, and I realise that's sort of the paper surveys and stuff, obviously there's not a great deal of feedback from under 30-year-olds. And I'm just kind of wondering how we can kind of tap into that, because clearly we want to hear what people under 30 think and feel. So I think it's really, really important to do that. But those are my points, really. Thank you.
Yeah, definitely. And we met with the My Time Young Carers charity, and we did a workshop with them to have a look at our CRISP website. So that's our website for carers. And they gave us some really good feedback. And it's interesting, because with carers, we're looking at an audience that spans, like the age from 18 to 100. So it's really difficult to look at where you target your websites and your social media. And the feedback we got from the young carers was really interesting. And they told us they like to see videos short videos of things. They use TikTok, for example, rather than Facebook. So that was really helpful for us to find out what it is that they look for, and when they're looking for information, where they go and what they do. So we're really keen to engage with younger carers. So we've already started that, and we're working with our children's services as well, so that we can ease that transition when someone moves from services into adult services, children's services to adults, sorry, then we want to make sure that they know what's out there, that if they're a carer under our children's services, that when they become 18, they know how to access CRISP and our services, and that we make that accessible to them, and that we change our social media presence as well, and make sure that it is actually suitable for all ages, and change our website so that it's interesting and it's something that they would want to look at.
Thank you. Betty.
Yes, thank you, Chair. And just to pick up on some of what Emma said, we are really looking at our comms and how we communicate and how we get our messages out there. I think what we're also really keen to do is to work with those that are transitioning over, because they will be the adult carers of the future for us, and we want to give them the immediate support at the earliest opportunity. I know that Tim is on the call as well, Chair, and Tim is our operational lead for carers, and he's been doing a lot of work around how we bring our carer services to the carers rather than always expect them to come into forums where we're present. And I think that's one of the really key things that we're trying to drive forward, especially as we go into the ICS and all those things that are much more local. So the carers actually, we're where they are in their community groups and their community hubs, as opposed to them having to travel to get to where we are. So that's something that I'm really keen to really progress. And I know Tim is as well, with Emma and our other colleagues, but as a whole wider system as well. So, because my view is we can't do enough for our carers, and we should do the, as much as we practically are able to do and what's within our gift to do, because they do so much for us and for their communities and their loved ones as well.
Sorry, I think I missed Tim off. Tim, are you there?
Hello, yes, I'm here. Thank you.
Yes, it was nice to see you last week at the Carers Action Day, which looked like it was very well supported, sort of down there. I mean, I'll just put you on the spot here, but did you want to say anything about that was down at Kinson?
Well, only to say I think we've had some really positive feedback from those carers that commented. I know we've had a lot of people reflecting on the day, and they were certainly saying that they walked away. It was a really nice opportunity for them to meet up with people in person for the first time in quite a long time, and certainly a lot of people went away with a smile on their face. So I think that kind of says it all. And we're doing some service planning next week, actually, where we're going to be really focusing on how we can maybe replicate those events next year, maybe do one or two more if we can. Obviously, with current COVID conditions, we've got to keep an eye on that. But yeah, that's our ambition, is to start to branch out a little bit more into those events, because clearly they are working and they're really well appreciated.
Yes, thank you, Tim. Councillor Butler.
Yeah, can I just put in a plea for maybe a booklet of carers information of what's all in one place, because a lot of carers don't know that things are happening, or they don't know what's available. And there are so many different organisations giving help, as well as council help. And it would be nice to have it all in one place. And I know that the listeners, the young people's listeners, did say that they like paper copies of information as well, that they could pick up. And that would also link in with any events that we did do, so that you've actually got a handout for people to take away that they can keep.
Thank you, Phil. Did you want to answer that?
Yes, and Tim and Emma, correct me if I'm wrong, but we do have a single point of information, the CRISP newsletter that carers can sign up to and get regular updates around services that are available, advice, information, guidance. So if it would be helpful to members, we can attach that link to this to the notes of the meeting.
Sorry, I was thinking if people go into a library or somewhere and they just pick up information, you know, if especially people that we're not seeing at the moment as carers, people that don't always ask for services, you know, the more independent people, maybe. The people who are out of the loop, that's who I'm trying to get to, which is, you know, what we mentioned earlier. Yeah.
Yeah, Councillor Butler, that information around CRISP does get posted in things like doctor surgeries or GP practices, pharmacies. I think I'm right in saying, Tim, that it's also in libraries, where so that it's that access point. Once you join it, all the advice there. We can't keep the fact sheets updated and posted in, you know, in many outlets. That's not the way that people want to access information generally now, anyway. So it is there as a focused place for a response. And some of that might just signpost you to other publications that can give additional helpful advice from Carers UK or wherever. So we are trying to keep it so people can go to one place, and that's widely publicised.
Thank you, Councillor Butler. Actually, Diana brought in a very useful booklet called If Only I'd Known That, One Carer's Experience, and there is sort of information in the back of that sort of would help, the sort of thing that would be quite handy if you had some, you know, not to be removed maybe from libraries, or if they've got lots of them, to keep them in libraries that they can take home.
I can actually get extra copies for anyone.
Councillor Evans.
Thank you. As a local GP, until I actually came along to this committee, I had never actually heard of CRISP. So I think some work certainly needs to be done about promoting the service and getting information out there. I believe also maybe looking at the name and things like that as well. Is that correct?
Yes, that's something that we've been talking to the Carers Reference Group about, in terms of the name particularly, because we're of a similar view. I think that it's maybe not as meaningful as we would like it to be for a lot of people these days.
Councillor Johnson.
Thank you. My question really is, does information get sent out when carers allowance is awarded?
So I'm not sure that we are automatically notified when somebody is awarded carers allowance, because that's a different organisation obviously that's doing that. So there probably would be data protection issues there. But certainly we make sure that anybody that's in contact with any of our services is made aware of the Carers Information Service and CRISP, so that they're obviously put in touch with us that way.
Thank you, Betty.
Yeah, thank you, Chair. And just to add a little bit, mainly on your point, we are trying really hard to get into forums that we're not currently in, because we do appreciate that people sometimes won't pick up literature, especially if they've gone there because they're in a crisis anyway. You know, they might not be conscious of what's around them. So things like the health village that's starting up in Beales, and that kind of thing. Tim's working really hard to try and get a space in there, so that when people come through those doors, and if they're potentially carers and maybe doing some caring that they don't even realise that they actually are a carer, and start to try to pick those individuals up there and try and offer them support, you know, even before they probably even consciously recognise that they need that support. So for me, it's about really tapping into the forums that we already have and the information in the literature, but also being as creative in the areas that we haven't got a real presence in yet, that we want to build up those presence and really do some proactive work.
Thank you. Can I go back to, you had on what we plan to do, your objectives, How did you get on with the objectives? What sort of seemed to be very difficult in fulfilling, and which ones have you succeeded in?
Can you remind us which page you're looking at, Chair?
Page 38.
Thank you. Get there in a moment. So this is in the Valuing Carers in Dorset. So this is the strategic vision that Emma was talking about, that we're working jointly with Dorset and the Pan Dorset Carers Steering Group. So we are actually in the middle of an exercise at the moment where we are literally reviewing each of the 9 objectives. We've had 1 or 2 workshops, but we're wanting to take quite a broad view and get as many perspectives on that as possible. So at this stage, I probably couldn't feedback specifically on these because it is something that we're in the middle of doing at the moment, but it will feature very heavily then in the next iteration of the vision when that's created, which we're expecting to be sort of middle of next year.
Thank you, Tim. So I presume when we have this brought back to our committee for an update, sort of that can be included in that, can it?
Well, one of the main things we've been focusing on is obviously what Emma was saying, and that's our own BCP strategy. Depending upon when we're next back in along to the committee, obviously if there's an update on the Pan Dorset vision, then we can certainly deliver that at the same time. So that's fine.
So thank you, Tim. And any questions from anybody else? Anybody online there got a question? Not got your hands up? So we've been asked for 3 recommendations. Firstly, to consider and scrutinise the contents of this report, which was a very thorough sort of report and very welcome, because we're all aware about the sort of stress, especially this last 18 months to 2 years, that a lot of our carers have been under. And secondly, committee to consider attendance at future informal carers strategy engagement sessions. Does that committee feel that we'd like to be involved in that? Yes, thank you. And the committee requests an update at a future overview and scrutiny meeting. So I think that would be very welcome as well. So that will be something on the forward plan a bit later. But obviously this new survey is only just going out, so that will be quite a few months down the line possibly. Okay, thank you very much, Tim, Emma.
You're welcome.
Thank you.
So we're now jumping on to which was agenda item 9, which will be our agenda item 8, and that's the Home First Review update paper. And can I ask Betty Butlin to introduce and present this item, please? Thank you, Betty.
Thank you, Chair. Yeah, this is the second report that's come back to committee. The first report was in January, the 18th of January, and this is a follow-up that was requested by committee back in January. So the committee is asked to note the content of the report and scrutinise the progress on development so far of our Home First model. So I will talk through some just key points, highlight some just key points in the report, and then take any questions. Thank you. So just a reminder that back in March 2020 that the Department of Government published some guidance around hospital discharge service requirements in line with the onset of the pandemic. And as a Dorset system, Home First programme was established in response to the national mandated requirements to implement discharge to assess, which is a model that each local system needed to introduce in order to assist in discharging individuals from hospital at the earliest opportunity. And the kind of main reasons for the introduction of this guidance and policy was to free up hospital capacity and to streamline discharge in order to make sure that we had the right staff and the right services available just at the very early onset of what was the national pandemic, well, the global pandemic. So during 2021, funding was available. Funding continues to still be available to support those individuals leaving hospital that have either an enhanced need or a new need of care. And that funding is at the minute anticipated up until March 2022. So within the system, especially within BCP Council, we continue to provide dedicated workforce that support this programme of discharge to assessed, with various roles undertaking commissioning of brokering of care, of assessments of need as being part of the overall multidisciplinary team, providing a 7-day service really centred around helping as many people as we possibly can, enabling them to take the right pathway following their discharge from hospital. And there are a number of pathways that are set out within the government guidance, and I've referenced those in the report. Pathways 0 to pathways 3. So I'm not going to go into details, but happy to take any questions on those. So significant progress has been made since March 2020 with our NHS and our community and voluntary sector colleagues around our infrastructure of how we're continuing to support individuals during this very difficult time. Some of the progress I've noted, which is very practical, progress such as the appointment of a system flow director for the system, some other stuff around capacity for winter, additional capacity, and the work that we're continuing to develop as part of our long-term home first approach. And that's that. I've listed some of the stuff there for you as well, and just some stuff on our performance. We do know that our systems are struggling and continue to struggle, as is common nationally, around being able to get people safely discharged from hospital whilst maintaining flow within our hospitals, and our community hospitals are also included in that. And we do know that our system, along with many other systems, struggle periodically at times for those people who no longer need to reside in a hospital bed to actually be able to leave to a different journey, be that at home or in a short-term place until they recover. So I've listed just some of the actions that we've taken for improvements, and a lot of that is around additional capacity, both of beds within our communities, i.e. within residential and nursing home beds, and also much more domiciliary rapid response care, as well as how we're doing our calm strategy and multiple other things that I've listed within the paper. And then I give you a bit of an update on the summary of the financial impacts on page 6 that you may wish to take into account. What we are tangibly seeing is the people who are leaving hospital with an enhanced need of care. So they have greater care needs at the point of discharge. And we know that people leaving hospital on average, those that we are supporting, leave hospital with around 28 hours a week care. And we know that once we pick them up as soon as they've left hospital, that then we are reassessing and working with them. And on average, that goes down to about 19.5 hours. But we also know that compared to our community cases, which are around about 14 hours, that's about a third more nearly. So we are very conscious that there is a greater need, there's a greater level. And then, of course, that puts more additional requirements onto our domiciliary care providers, as well as financial implication of that, and the need for more staff to be there to quickly assess and continue to assess. So, Chair, I think that's me picking up the key points. And as I've said, happy to take any questions based on the report.
Thank you, Betty. Can I just sort of say the equipment service, I don't know if that's under you, but absolutely excellent. The speed that they get out to the people and the equipment that they give them to use, I think sort of second to none. So congratulations to that team. Members, any questions? Councillor Butler.
Yeah, just from personal recent experience, this isn't in this county, it's in another county. One of my relatives overestimated what he was able to do leaving hospital to go home, and the hospital literally sort of threw him out and he went home, and we had to hurry around to get him a care home to go to. Now hopefully that doesn't happen here, but how do you ensure that the person you're interviewing, assessing, is actually being realistic with what they're able to do?
So what I would hope happens, and would happen in most cases, if not all cases, is that at the point of that discussion around how is someone going to go home, especially if it's someone who has got needs, and maybe there's some issues around their level of being able to maintain information, capacity, stuff like that, then we would want to be having conversations with other family members who have been involved in that, provided we're able to give consent and it's, there's no safeguarding issues or anything like that. So we would gain as much information as we possibly can from their existing support network, and then we would factor that into any care provisions that we would be wanting to take forward. What I would just stress at that as well, any service provision put in at the point of discharge should only be temporary at that time until that person is back in an environment where you can assess their needs in a much cohesive way with them and everybody else. And then that's our kind of concept around, we will discharge and then recover and then assess your long-term need, which is absolutely the way things should be done and is much better for that individual. So I would hope that things don't fall through the net like your situation or your relatives, but if it did, I would also hope that people are able to come back into us really quickly, and then we would pick that up as quickly as possible. It is very, very busy, and sometimes, hopefully very, very seldom, we may need to do that, but we would endeavour to have those really early conversations at ward level.
Thank you.
Thank you, Councillor Evan.
Thank you, Chair. Very quick question first of all. Pathway 2 and Pathway 3, could you just clarify the difference between them?
So, Pathway 2 is those people who would be discharged into a recovery bed. So it could be someone who's non-weight bearing, for instance, has had a fracture, their hip, they've had some kind of orthopedic issue, and we know they're going to be there for a set period of time. So we know that they need that at the point of discharge, or there may be some other situations where we know it's very short term, but it's for rehabilitation. So that person will leave. We know they're not going to stay there. Pathway 3 is for people that have very high level complex needs. It's a very small percentage, but it is very likely those people that will remain in residential care. So at the point of those individuals going into that environment, you know that is probably their longer term need as well. And we do both every day.
Thank you. Could that be clarified better in the definitions?
They're not my definitions, they're the national definitions.
Right, fair enough.
So I don't think I can
change them
as much as I might want to.
So basically Pathway 2 is a rehab bed, and Pathway 3 is a probable permanent admission to a care home.
Absolutely, and just those of us who are in the system, we've had those discussions in clarity to make sure that we're all, but I do appreciate looking at it. It might not be that clear.
Thank you. So moving on to the performance figures, obviously these are unprecedented times and the whole system is struggling. It says we've currently got 250 to 300 people waiting to discharge and therefore blocking beds in hospital. How long is the average stay for those people, please?
So this, as I always say, this changes all of the time. There, I look at information from our hospital dashboard in the morning, and it may be different in the afternoon. So situations change several times throughout the day. On average, it's 250 to 300, and what we're saying with that is that a percentage of those are actually in hospitals. So some in UHD and acute hospitals. There's other environments where people might be in. They could be in a community hospital also, which is slightly different. So just wanted to point that out. So I guess the kind of things that we're trying to do with that, because it is very difficult and it's very challenging to get those numbers down. What we're trying to do is put additional capacity in, put additional dom care support in. I've kind of listed some of the kind of stuff that we're trying to do to improve that performance. We know that performance is going to have to improve even much more than what it is now. It's going to have to get much, much better because we're entering into a winter that is like no other. And we know that we're struggling already today, and to continue to struggle with a more fierce winter and with possibly a greater need, we're going to need to have other services at our disposal, and that's the kind of stuff that working really closely with Phil and Elizabeth on commissioning. We challenge ourselves on our performance all of the time, but the performance, it is very difficult to maintain if people are coming into emergency departments and then they need to have a bed, and then there are people who need to leave, but the resources might not be there right away for them. So that kind of stacks up those that clinically are deemed to no longer need to reside against those that need to come in. And one of our biggest challenges as well can be areas like critical care, which is really important that that we have scope and capacity within critical care. So it is a constant repositioning of what we have available and how we're using it. I'm sure some of you can absolutely relate to this in your own kind of areas of practice. But we do it collectively. We talk constantly throughout the day. Everybody does what is within their gift and their power to really, move things forward and get people to where they need to be. And more importantly, try to free up enough capacity for those people that need to come into hospital, because they really need to come into hospital.
Thank you for that. And yes, we do completely understand the pressures that you are under. But I'm just wondering, for an individual patient, what's the average length of time this is taking?
So again, this will differ depending, and I'm not intentionally not trying to answer your question. This will differ depending on, are they going home? So then it'll be dom care. Are they going into a placement, or are they going, back to a family member who's somewhere else? This could be anything from 7 days to 15 days to whatever. I wouldn't want to be drawn into a kind of guesstimate of length of stay, because it's very different at the minute length of stay compared to what it was before, because of all of the pressures on the hospitals and the D2A, the whole multidisciplinary process of discharging now.
Thank you. Is length of stay not part of quality improvement and monitoring though?
Yeah, of course it is. Of course it is. But what I guess what my point is, that length of stay is it varies so much. Prior to COVID, we would have aimed for a length of stay around 7 to 9 days on average. And again, these are very average things. but because we're in the middle of a pandemic and we're facing different types of situations and scenarios, it's not always easy to work out the average length of stay as readily as it was before. We know how long people are staying, but it's around how long are they staying for when they become medically no longer needing to reside, and then do they dip, and then do they come back? There's so many multiple factors within this.
Thank you, Phil. Do you want to come on?
Yes, thank you, Chairman. I just want to add, and Betty's articulated really well the pressures in the system. And I just wanted to put in the context around workforce as across the whole of the system. So we know the NHS is struggling at times to recruit, particularly therapists, and that has an impact in the community when you're trying to get people to recover. We know that the independent sector in social care is struggling to recruit and retain staff, and many staff leaving the care sector because of the pressures they felt, and that's equal for NHS staff over the last year and a half and more. And there's been no let up in that pressure. People working extended hours, weekends, overtime, and it's a struggle to recruit, and it's really difficult to find a workforce within our system and our area that is willing to work in care, whether it be the NHS or social care. So I think we just have to recognise that it's a pressure. It isn't just about how quickly we can get someone discharged from hospital. Of course, we want to get them out and we want to get them home, but a quality improvement programme isn't going to make any difference if you can't get the workforce to support the people that need the support. So, and we know, as Betty said, that the needs of people leaving hospital now are at least a third higher than they were before the pandemic hit. So we're dealing with a high level of acuity of care, so a high level of need and complexity, and quite often people need two people to care for them, not one. So that puts an additional pressure on the workforce that we do have. So I just want members to understand that the workforce that is there is working harder than it's ever done before and supporting higher levels of need than it's ever done before. So we need to applaud our carers, whether they be informal carers or whatever word we choose to call them in the future, paid carers, and of course our NHS colleagues.
Thank you, Phil. Yes, I think we're all sort of quite aware the strain the care staff and those working for the NHS are under at the moment, and how hard it is to recruit and retain them. Councillor Evans.
Apologies, I know we're meant to denigrate all the work that everyone's doing. I know everyone's working incredibly hard. The reason I wanted to clarify the figures was just to show the problem, not to say that we're not doing everything that we absolutely can. I just think sometimes data can be helpful to say, this is how serious it is, this is how bad things are, not to in any way say that we're not doing everything possible to try and address that. So if that came across, I really apologise.
Can I just ask you then, Betty, do you think that we need more reablement places such as Coastal Lodge, which does a really good people go in there from hospital and they say they've broken their hip or something, and they get them walking again, because there's much more intense physio going on there. So do you think we need more of those sort of places in this area? And also with the extra care housing strategy coming up, with the availability of that perhaps for people that would end up with a more long-term problem, that sort of housing would be better for them. And is that something we need to look at? Because, people are getting older and living longer and getting more complex needs, and that so we need to look at how we can get them out of the hospital.
So I will, if it's okay, Chair, Phil will probably want to add to this as well. But we have commissioned additional beds, and that's part of our kind of strategy with our partners. So we've commissioned, I think it's around 2,400 rapid response additional hours. We've got extra interim beds, and some of those are around in Coastal. And we're looking at other areas around reablement that can produce reablement. The beds that we are commissioning in all of this extra capacity that we're doing as a system, what we're doing is we're commissioning beds that have wraparound therapy within them, but also where we can have therapy from our communities or our kind of hospital environments that can go in and support those people as well. So we're very, very attuned to the fact that people leaving the hospital will need to have some therapy, will need to have some reablement and rehabilitation. So looking at what we're doing currently now, and what we've kind of, we will continue to do, is to make sure that we have that therapy element within a lot of the services that we're actually commissioning now. And I don't know if Chair Phil might want to add to that as our Director of Commission.
Just very briefly, Betty, because I think you've covered all the main areas. I think I've just come back to the point, it's really difficult to recruit therapists at the moment. They're not coming through university, but not in the numbers that we need to meet the demand and to work in the area. People are happy to go and work lots of places, and BCP is one of those, but there's not enough of them to go around. So that we can buy more beds, we can buy more home care, but we need that expertise that gets people rehabilitated and gets their functionality back, because that puts less demand on care for the longer term. But on your case around extra care housing, Chairman, yes, we can, in that model of housing with care there available around the clock, then it can be a better environment for someone who's struggling to cope in, say, a larger home on their own. And you've got the care and support, and you can get reablement or therapy input into that facility as well as your own home or elsewhere.
Thank you. Councillor Phillips, you got a question?
Thank you very much. Thank you for the presentation. It was very open and actually has made me a lot more comfortable, and you are working so hard, and thank you. Betty, the news today announced that over 400,000 elderly and disabled people are currently waiting to be assessed by local councils. Does this cover, is this the figure that is all of the councils and the work that you're doing, or is this something separate? I just would like to be clear for myself.
So I haven't read what you've read.
It was on the news all day long today on channels.
Yeah, I haven't heard the news all day. But what I would say is that every area nationally has got some degree of a waiting list, and I think that's what that's referring to, just from what you've just said. And I think that's a real challenge, particularly in the pandemic. We have what we saw at the very early stage of the pandemic is people not wanting to come to services, people not wanting to come into adult care or go to environments that took them out of their home because of the kind of risk associated with COVID, and not really kind of, you know, back when it was in its very early stages. What we're seeing now are people that have maybe a greater level of need to what they had when they didn't come because of all of their concerns, and the volume of number then going up and being able to get to those people in a really timely way. So what we're doing within adult care is when people come in for an assessment, when they refer into us, what we're making sure is that we have immediate contact with them, even if it's to say, you know, we're aware that we need to come out and see you. Please bear with us. We'll get to you as soon as we can. But if your need changes, you know, or it deteriorates, or if you feel that you can't wait, you know, do come back to us right away, and we'll give them, you know, a contact number for that. But I was on national stuff last week, and there is not, this is a common thing now nationally, higher waiting list, higher level of demand, and higher level of need that is altogether is just increasing the numbers of people that are unfortunately waiting for assessments. And I would just echo what Phil said around therapy. we know that therapy is a real big area of where people are waiting, and workforce is a real major issue. But we are trying to get to everybody. What I'm doing at the minute with David and Phil and others, I'm doing a stock take internally of everybody who is on our waiting list in adult care. So that would be any adult over 18, no matter if they have a learning disability, a mental health concern, or a long-term condition, an older person with a long-term condition, or a younger person. And what we're doing with that is then we're looking at everybody who's been waiting, how long have they been waiting, and what level is that at? And then we're going to put an infrastructure in place, a number of recommendations as to how we might be able to manage that. And workforce will feed into that as well, because workforce at the minute have already got very high levels of casework, and it's around how we keep reprioritising some of our priorities. But we're doing a stock take, which is further ahead than some other areas, because we want to get to grips with that. And I'll be able to share that with you around what are our actual numbers and who's waiting and what type of care provision are they actually waiting for, and what are we going to do to try and improve that situation for them.
Betty, thank you. That's been extremely helpful. Chair, could we bring this back at our next meeting so that we get an update and a follow-on?
I think that would be a little bit too soon, because our next meeting is in January. I think it would, you know, we've got to get over the winter first.
Sure.
I think we need a good few months before we can look at this again.
Okay, yes. Time. Yes, thank you. Thank you very much.
Betty, can I just ask you, on page 197 with your graphs, people not meeting criteria to reside, local position by acute site. The Royal Bournemouth Hospital doesn't have as many peaks and troughs as Poole Hospital. Is that because they're looking after different sort of patients with different needs in there?
Both are acute hospitals, but they do specialise in some different areas. You know, one may specialise in something that the other one doesn't. That's probably one of the only differences, other than the hospitals have recently come under UHD. You know, they've recently formed, and I know that on the RBH side, they have had an interim team, maybe a bit longer and a bit more established to maybe what the Poole side had, but now they're beginning to share resources across. Well, it's one organisation, isn't it? It's University Hospitals Dorset. So now we can flex service provisions and teams across both, bring the expertise from one site to the other for the benefit of both sites, if that makes sense. And that work is definitely something that's going on now. So I would hope that we begin to see a more balanced kind of levelling of those on each of the sites. That would be my view.
Okay, thank you very much. Any other questions from anybody? Councillor Robson.
Yeah, you sort of alluded to this as a national problem, which I sort of can fully buy into, having an experience from an out of area situation. But my question is just coming back to is there a national pathway, or is a plan or strategy for a national pathway for carers? Because I feel your pain and take my hat off to you for what you're doing, and recruitment, you know, being what it is. The recent experience I've had is that various care companies have recruited below the level of what I would expect as a care package, which has actually resulted in the person being cared for going back into hospital when they shouldn't have done, because the care was inadequate and, I'm not going to say on the cheap, but probably recruited without the experience that they needed. I was wondering whether there was a national strategy for a care standard coming through or anything like that.
Thank you, Phil. Do you want to take that question?
Yeah, that's a really good question, Councillor Robson. There is and there isn't. it's a double-edged. There's national recruitment strategy at the moment, but what it isn't setting is a minimum requirement for, well, certainly for the salary for carers. Although there is a proposal that there should be, so there's a national living wage, which is what we pay, or we recognise in our fee levels. We're one of the highest fee payers certainly in the country, and certainly in the southwest. Probably only the southeast that pay more than we do per hour. That's to recognise that we want our providers to pay a fair rate for the care for the care workers, so that they get a good hourly rate. That I think it's different in different parts of the country, and some councils pay very low rates. We don't, as I've just said. So we would not expect that to be the case. But I would also say that Betty and her teams, and Betty can answer this herself, of course, we don't under-prescribe care. We prescribe the right amount of care, but we look at it holistically. So what can your family and friends also do to support the informal carers? We only want to do as much as someone's needs. We don't want to over-prescribe care, because that makes people less independent, takes away their independence, and makes them very reliant on care. But we do our best to give the right amount of care and the right amount of support that's required. But I think nationally there is a potential through the government's reform of social care to look at how they can address the care workforce and make sure it's properly remunerated. But that would require significant central government funding.
Thank you. I don't know whether any of you saw an excellent two-part series by Ed Balls about the life of a carer, but I think they were in Yorkshire paying a lot less than sort of pay down here, so that might have made a bit of a difference to it, but I can certainly recommend it. I think it was BBC. There are other TV stations available, but definitely worth watching. Councillor Evans.
Thank you. Seeing as we've moved on to money, the financial impact assessment shows we're looking at a budget pressure of about £2 million, probably going to be even more. Is any of that funding going to be drawn down from central government, or is that something that BCP Council is going to have to cover?
Sorry, and David might wish to come in here as well. So we do know, as a result of the factors that we've kind of mentioned in the pressures, that we do have around 1.5 million, and then there's around another just under 450,000 pressure, which amounts to about 1.9. I guess there has been some money made available to councils that has come down for management of COVID very specifically. And you know, there is some money that has gone into BCP Council because of that. So we've been able to put a recommendation forward for us to have some of the kind of offset this against that, because all of what that money, that 1.9, that is all COVID related. If COVID wasn't here, we wouldn't have that additional pressure within adult services. So David and I and Phil and others have done that. So that's kind of how we're addressing that.
Sorry to ask one last question. We asked previously, could we have figures on failed discharge? Are we collecting them, and would it be possible to see those at some point, please?
So just for clarity, are you referring to readmission rates rather than failed discharge?
Apologies, yes, readmission within 24 hours.
So I knew somebody would ask me that, and I did try to get that. I tried to get that quite a lot, so I endeavoured a lot to get that, and I did speak to my health colleagues this week again. They have not been able to give me the information for tonight, so I'm not going to speculate in any way on readmission rates, but they have said that they will send me something. So when I get that, I will absolutely share that with you. And tonight, just before I come over, I just double checked that weren't about to send me anything, and they weren't. So yes, I will get you some stats, because that's for our health colleagues to provide that to me. I wouldn't even hazard a guess at readmission rates, because as you probably know, it's got multiple factors within a readmission. So if and when I get that from our health colleagues, I will certainly share that with you.
Okay, thank you very much, Betty. Yes, thank you for bringing that to us tonight. We can move on to the next agenda item, which is an update on the Dementia Services Review. Mark Harris, have you managed to join us?
Yes, I have. Sorry. Can you hear me okay?
Just about. I don't know if we can turn it up a bit. If you could just bear with us, we're just seeing if we can turn the volume up. Would you like to try it again, Mr. Harris?
Yeah, sure. Yeah, is that better? Sorry, I have a few problems with my microphone and my laptop, I think, sometimes. Can you hear me okay now?
Is everybody okay with that? Yes, yes, thank you. Yes.
Great.
If you'd like to go ahead, please.
Thanks, Chair. So in your packs, you have a report which updates on the Dementia Services Review. So you'll recall this has come through committee probably a good 2 years ago now, and unfortunately the implementation was delayed because of everything going on around the pandemic, and a number of other factors. Pleased to say that we were able to start the implementation from the 1st of April this year, even though it's quite challenging, obviously, with the pandemic still ongoing. Just to reflect on the key elements and the changes that the Services Review recommended and we were implementing. So we were changing the diagnostic model for people to come through for a diagnosis of dementia. And the change with that was to sort of a central point really into the memory assessment service. We increased the capacity in the mental health service, in the memory assessment service. And we've also looked at the workforce and skill mix. So started to look at complex and non-complex presentations. And thinking about the workforce challenges that have just been referenced in the previous conversation, recognise that to a point where we were thinking actually we needed to move away from just psychiatrists diagnosing to sort of looking at a much more multi-skilled and multi-professional approach to that. So what we've successfully managed to do now is bring in advanced care practitioners or advanced nurse practitioners into that diagnostic model, whereby non-complex cases go through that pathway with support from the medical psychiatrists as well in a multidisciplinary team approach. And the more complex cases obviously then still go through psychiatrists as well. So that's been put in place. We also have then the post-diagnostic support, which was a big area that obviously was found wanting when we did the review. And we've initiated a dementia coordinator role and commissioned that through the voluntary sector with Help and Care. And that again has gone well. They've sort of rolled out and recruited into their service very well, and they're embedding themselves in each of the primary care networks at this time. And they've had a number of referrals come through, I think well over 1,000. And the idea of that role really is to sort of follow people through from diagnosis through to the end of life stage, really. So recognizing that people move through different phases and different stages of the disease, and as a result have different levels of need. The idea of the dementia coordinator is to sort of almost handhold people as and when they need to be supported to access different parts of the health and care system. The other bit around that is that they're able to sort of embed themselves in primary care and become much more sort of in tune with some of the physical health elements that people have as they get older, but also some of the other primary care developments such as social prescribing that they can avail of as well. So we're really working as part of the broader primary care team. Cognitive stimulation therapy is the other element of post-diagnostic support as well, which is now sort of has kicked off basically, and we've got that running. And carers emotional support workshops as well, which were a very important part to sort of recognise the need to support carers and obviously inform them and educate them around the options that are available to them. We're also running memory roadshows, and that's for people that may have concerns around memory and relatives of carers to come along. And the idea is that that will move around the county. Some of those things have been impacted as we've tried to implement, obviously, by some of the restrictions around COVID, but things are moving forward and everything is up and running now. One of the things to point out, which you'll see within the report really, is that we have had unprecedented demand upon the service since we've implemented that. So the number of referrals through to the memory assessment service has significantly increased, and we're trying to understand what is underlying that. So obviously we modelled numbers through our dementia services review. We do think that part of it is linked to the pandemic. So there was a period of time where at the very first phase of the pandemic last year, we stand down the memory assessment services that were because of staff difficulties, but also about sort of shoring up some other sort of areas as well. So there's a backlog that sort of developed from that, but also I think the promotion of the new services has obviously brought people out and sort of got more referrals coming through from primary care, alongside the fact that I think the social and mental decline of people from being isolated. That's one of the areas I think that dementia specifically, and for older people, we've definitely seen an impact. And I guess that ties into some of the conversation that was just had in the last agenda around sort of more complex people coming through. Alongside that, I think probably families are starting to recognise cognitive decline a lot more, as well as they're in more contact or as they visit people, especially as they've come out of the isolation or the lockdown periods. As I said, the referrals have sort of increased quite significantly. They've started to plateau out a little bit in the last couple of months, and we're keeping an eye on that just to see what potentially is becoming the new normal. One of the areas that we've consistently been challenged on pre-pandemic is around hitting the national diagnostic rate, which is set at 67% of the primary care registers. So there's the primary care will have a register of people with diagnosis, sorry, with what is a prevalence of dementia. The idea is that we're supposed to hit 67% of those registers. There has been a challenge back over many years around whether those exist within Dorset, and unfortunately I can't split out BCP from Dorset Council in terms of all the rates. We've had a lot of modelling done and sort of analysts look at that from a public health perspective. So one of the things that we're sort of trying to unpick really is whether we can get to that 67%. You'll see in the paper it's dropped off quite significantly since COVID impacted upon us, and that mirrors the national picture. So we've dropped back down from about 63% where we were pre-pandemic down to 55%. So that's quite a significant drop. Some of the things that we need to understand really is the numbers at the moment, and if you recall, you probably would have seen some information in the media around this cohort of the population being disproportionately impacted by COVID as well, and the number of deaths. So we just need to understand that too. There is a lot of work going on to try and improve those diagnostic rates, and they're set out in the paper as well. We do have a diagnostic task and finish group that looks at sort of any interventions that we can sort of pick up and any initiatives to try and improve that. A lot of it's about bringing people in and making them more aware of the service, less so within the BCP side of things, but more in the rural areas is where we see that there's lower numbers of referrals coming through. So we're trying to develop links with the Farmers Association and a few other rural groups to try and raise the profile and think about the importance of coming through for diagnosis. The other thing just to touch on is as part of the recovery from COVID, we have been allocated non-recurrent financial funds to come down and sort of prop up the assessments and diagnosis team really. And we have tried to recruit some additional workers in to bolster what the actual model has put in place already. So again, the idea of that is to try and catch up on the backlog of referrals that are there. We have had some challenges in recruiting to all those posts, but I'm pleased to say in the last couple of weeks we did recruit to a full-time medic, which should be giving us an extra 50 slots per week in terms of assessment. So that should start to make some inroads into our current numbers, but also start to make some inroads in reducing waiting times as well. And that's about it, really. I think the other thing to point out is obviously we will evaluate the whole thing, the whole model, and look at the impact of that in due course. We need to give it enough time to sort of bed in fully, recognizing that what we're in at the moment is not normal times. But we are looking at the key metrics that we will be sort of collating around that, which will include waiting times, diagnostic rates, but more importantly, experience of care as well, and carers. So we will be working that up. The aim is to look at doing an evaluation probably towards the beginning of the next financial year. I'll leave it at that, and I'm happy to take any questions.
Thank you. Members, any questions? Councillor Butler.
Yeah. Can I ask you, do you ever use any student nurses, psychiatric student nurses for your assessments for dementia?
I probably wouldn't be able to answer that honestly, because I'm obviously working in the operations service, but I wouldn't see student nurses as doing the assessments around the diagnosis. As I said, it's a skilled activity, and when we did the review, it was very clear that we needed to have a specific competency around that. Student nurses would probably sit in on the assessments, but I wouldn't expect that they're actually doing the full assessment to sort of understand whether someone has got dementia or not. That sits with, as I said, the advanced nurse practitioners or the advanced care practitioners, which are more senior clinicians, and then the psychiatrists themselves.
Thank you. Councillor Evans.
Thank you. I think this has been an amazing piece of work and should revolutionise some of the care of our population suffering from memory problems. And to do it, in the middle of a pandemic is just amazing. So, absolutely well done. Obviously, there is a backlog and we're looking at about 800 people waiting for first assessment. What's the average time this will take?
So at the moment, the average waiting time is about 15 to 16 weeks. But as I said, with the extra 50 slots that are coming in a week, we expect to see that reduced down over the coming months. So one of the things that we did have a challenge with pre the review was the waiting times for assessment, and that was one of the key aims and objectives really, was to improve that. So our objective and our aim is to get that down to 6 weeks. So we're some way off that at this moment in time. But as we work through that backlog, I'm hopeful that we will be able to get that down, subject to maintaining the workforce, basically.
Thank you. And what interim measures are put in place for those people kind of left in limbo?
So we have the memory roadshows, we also have the carers workshops, and we also have sort of the dementia coordinators as well that are working in primary care. So again, linking all those elements together, there is obviously that advice and guidance that's available for people to sort of have that communication through. So it's not ideal, and I think we recognise that we definitely need to improve the waiting times on that side of things.
Thank you. Can I just ask you about the quality of the GP referrals? That you didn't seem. This is page 107. You didn't seem to manage to get many GPs to respond to you. Have you managed to get sort of more to respond to you for the GP referrals? Because obviously this is where a lot of the people will go first, isn't it, to see their GP?
So that's the actual business case, isn't it, that you're referring to, I think, from the review. So, so what we have now is obviously that, I think in the past what we had was a kind of a mixed and complicated sort of approach where we had a gateway which wasn't working fully. And that's what we've done, is tried to simplify that out now. So we've got much better relationships and better connectivity between the actual memory assessment service into primary care and the GPs. So we have relationships built up between sort of the actual psychiatrists working in the different localities with the sort of clinicians at the front end in primary care. So yeah, the referrals are coming through from primary care, and when you look at the numbers coming through, that I think that signifies that people are getting through now.
Okay, thank you. Anybody else got any questions? Can I just say on your figure for the dementia growth projections, which is page 93, the forecast of dementia prevalence across Dorset, I think it perhaps might be useful to have our population figures in with there as well to know, because we do know certain parts of BCP have older people living in it than other parts, certainly across Dorset as well. I mean, we know, is it Christchurch has one of the highest number of older people? Yeah. So I think if we had that, so because if we look at it, we can see that Christchurch, you know, sort of, we could compare that, you know, if Christchurch has got 810 and that's sort of a percentage of their population, we could see where this is sort of coming from. At the moment, it's just sort of figures, but it doesn't actually mean anything without the actual population and the age of the people living there. It would just sort of help a little bit, I think.
Okay. Yeah, I can look into that. I mean, I think that detail that you're taking from is from the actual review and the business case that we included as an appendix. But I can go back and I guess what we may be able to look at is see whether those numbers have changed. And I think that was the bit I was referencing before, is we really need to understand the impact of the pandemic and COVID on this specific area of the population, and whether that's had a disproportionate impact on mortality or not. But I can have a look and see whether that's available for the chair.
Yeah, just a very quick question on the supporting well. I didn't quite understand the step up, step down transition pathways. Surely if somebody's in a higher need of stepping up care, my understanding is dementia patients very rarely step down from a high level of care, it just progressively gets worse. Or is that not what that means? Or
so you're talking about the intensive community dementia service. So it's framed around crisis. So I guess the whole emphasis of the pathway is about more earlier intervention and working with people so that we don't end up with people end up in crisis as frequently as they might, and prevent hospital admission where it's possible. So ideally, the dementia coordinator has a very significant role to play within that and managing people through that life course. With the support of the intensive support team, then they will come in and work with families much more intensively to sort of look at how to manage behaviour, positive behaviour support, but also look at sort of changes in medication, and then working alongside the CMHT if necessary. The step down piece is when the crisis is complete. So you might find that you've got the community mental health, the older people's community mental health team, who will stay involved with people probably for a longer period of time, whereas the intensive support team will be in there when there's an actual crisis happening. So I guess the step down bit is around recognising the crisis is over and actually things have settled down a little bit. But that's not to say, as you said, it's a degenerative condition, so people will deteriorate over time. But it's more around the crisis and non-crisis.
Yeah, I think so. So my reading of that is it's the crisis team gets it to a more level state, or a point where it's gone through crisis into a point of no return, where almost a low level of care can be administered because it's gone beyond the crisis state. So as far as the family is concerned, maybe.
Yeah, I'm trying to think of an example of a story, kind of almost a sort of to bring it to life. But I guess it would be sort of if someone is at home and becomes very aggressive and sort of very challenging at home, that team will go in and support around there to see whether or not we can maintain that person in their own home. And it might be that then there's it ties into sort of some additional support that needs to go in. Or it may be, and when things settle back down, as you were saying, I suppose it's difficult to say that things get better as such, but once that behaviour becomes more stable and more settled, and perhaps the family are able to manage the presentation more, that the crisis team might step back, but there still be other support in there to keep that at that level, if that makes sense.
Yeah, no, perfect. Thank you much. Yeah.
Thank you. Anybody else got any more questions? So can I just ask Mark, can you just say a little bit more about the Memory Road show? I presume you were hoping to go out sort of face to face with people, and that of course may prove a little bit more difficult now. What sort of things were you going to sort of bring for sort of people on this? Because I mean, this is difficult, isn't it? We just had carers, but people caring for people with dementia is extremely hard, because very often they're caring for their partner and they see that partner change personality in front of them, sort of, you know, it can be a fairly short matter of time when it happens. So I just wondered what you were going to bring to this Memory Roadshow.
So that's part of the Dementia Coordinator Service offer, basically. And I think, as you said, the idea was to take that around to different communities. So again, it's raising the awareness of what memory problems are, thinking about some exercises that perhaps could support or minimize the impact of that, or try and slow things down. And again, it's sort of, I guess the idea is also to make and publicize as much as possible about all the different support options that are out there, so that when people are getting to those sort of situations, they know where to go to access that support. That was one of the other things that came through our view seeking, was that people weren't often clued in or sort of cited on where did they go to get that support when things were going wrong. And obviously, if we can get people to sort of come and identify some problems that are emerging earlier, then we can intervene earlier and help people and their families a lot earlier as well. I guess that's the whole premise really of a lot of the work that we're doing, is to try and sort of, you know, put that prevention in as much as possible, but support people through in a much more sort of planned way. So again, thinking about sort of the Memory Roadshow, it's again also thinking about when people get to certain points, what are the sort of things that family and carers need to think about for the future, recognizing again that this is a degenerative type condition. But as you said, I think that has been impacted, and I'd need to go back and check how many have actually happened at this moment in time, because of that face-to-face element, which has been pretty tricky and challenging.
Yes, thank you. Anybody else? No? Well, thank you very much, Mr. Harris, for a very informative report there about this very serious problem. And so I shall look forward to seeing a review maybe this time next year on how we're getting on with it, and hopefully the pandemic will be forgotten, but we can only hope.
all going well. Yeah, I'm more than happy to bring the evaluation back when that's complete.
Thank you.
Thanks very much.
Thank you. Good night.
Bye.
Can we move on now to our portfolio holders update? And we have one in person with us and one that sent their apologies. So, Councillor Iyengar.
Thank you, Chair. I've actually got some slides, and forgive me, I've sent them over to Joseph, and I wonder if these can be shown and I can talk through them. I know we've also got Sam Crow, Director of Public Health, dialing in as well.
Okay, who's going first on this? Hello, Sam.
It'll be me.
It'll be you. Okay.
Okay. Are we able to show the slides, please? Okay, thank you. Thank you, Chair. I'll carry on. Good evening, committee members. I think most of you know me, but for those who don't, I'm Councillor Mohan Iyengar. I'm the recently appointed Cabinet member responsible for active health, which includes all elements of physical exercise and particularly of late, the most important area of the liaison with public health, COVID resilience, and so on. And I'm very pleased to come here this evening and with Sam Crow, Director of Public Health, give you an update on the COVID-19 winter response. Of course, there have been announcements at the latter end of last week and also today. So I'd like to just share with you the presentation that was already prepared, but also just overlay it with a few verbals, as will Sam, given the very latest announcements that we've got. And I'll come to those. And of course, I'm very happy to take any questions. Next slide, please. The current situation, the infection rates are high. From, I think some of you can remember earlier on in 2021, we enjoyed relatively being at the lower end of the UK, but actually we are somewhat high. So infection rates are high in BCP Council and with our neighbouring Dorset Council. They plateaued, so the rate of increase has sort of levelled off somewhat, or has reduced. But you can see there in bullets 2 and 3, we're running at the rate of 592 infections per 100,000, or if you prefer, 0.592%. Dorset, slightly lower, or just about the same, shall we say. But interesting, the next bullet down, the southwest, is somewhat lower, and the England rate, 429. So currently, for those doing quick calculations, we're about a third above the national rate at the moment, which, you know, you might say is significant. Infections, the reporting is pretty consistent on this. It's highest in the younger age groups, and particularly a cause for concern, and this is the second to last point, is the twin peaks of the school-age children and then parents of obviously school-age children and the household transmission, and that's a particular cause for concern at the moment. Hospitalizations are rising, but they're only a very small number. The 97 per 100,000 is a very small number. I believe it was 4 or 5 times that number before we started the vaccination programme right at the start of 2021. If you don't want, I've got about 5 or 6 slides to go through, about 5 slides. If I can go through them all, and then I'm very happy to take questions, if that's okay, Chair. This gives the infection rate in perspective. On the left side of the graph is 1st of September last year, 2020, rolling through to the right-hand side there, which is where we are now, literally 1st of December now. Okay, and there's some call-outs there along the bottom. Oh, excuse me, next slide, I'm so sorry. There we go. So on the left-hand side is September 2020, and on the right-hand side is where we are now, December 21. And in blue along the bottom there, you can see just a few call-outs to mark some of the key, the sort of, I won't call them high points, that's probably the wrong word, but some of the notable waypoints along this journey. You can see there where we get to November into December, and if you're squinting to see it, on the left there, just where that major peak starts, that was in the start of December, January, post-Christmas, and then when there was, well, there was a lot of sort of, which shall we say, not so much easing, but the lockdown ended on the 2nd of December. It seems such a long way back now, doesn't it? But then we had the sort of meteoric peak then over January and February. And that's really before, you know, arguably many people were in the way of using masks and so on, space distance and all those things, and a significant peak there. So the lockdown 6th of January, then it calmed down, rolling through the early summer through May and June. And then, let me just abbreviate this story. We come into July, and then July was the last of those staged easing dates that the Prime Minister announced. And I remember it well from the tourism perspective, I think it was the 17th, forgive me if I've got the date exactly wrong, but July the 17th, when all restrictions were off. And of course, that was good for many of the businesses in many of our sectors, but then we had another peak around the summertime, when of course we had many visitors, not least in this neck of the woods. But what we're seeing now, if you go over to the right-hand side, is we're seeing a renewed peak again. And this one probably, and this is where I'll hand over to Sam very shortly on this, is this is one where it's not quite, there's more factors involved in this than there were earlier on in the year, not least with the variants as well, and people in mixed stages of being vaccinated as well. And I welcome Sam's further advice on that when we come to it. Can we go to the next slide, please? The vaccination programme, can I just put this into a bit of context before I talk about the bullets on this slide? The government's been running what's called the 5 pillars approach to the COVID resilience, where within the 5 pillars, and this is the so-called plan A of things, 5 pillars are vaccination programme, funding to the national health particularly and social care, the continuation of test and trace, the restrictions, the colour coding on international travel, and also vaccination for flu as well. So they're the 5 pillars of the so-called Plan A. Now, at the moment, there's no wish to go to what's called the Plan B, and the Plan B is where things would be, if they chose to, where things would be tightened up much further. And these include masks everywhere, which we can remember earlier this year, a stronger push to working from home rather than going to the office, vaccine passports, which, as you know, have not been used in this country, but that would be one of the options under Plan B, and then also much stronger messaging once again around the hands, face, and space. So I must stress with you, they're in the Plan B. They're not yet being implemented, but obviously they're there to be considered. So masks everywhere, working from home, vaccine passports, and the stronger messaging to everyone. And then, of course, the Plan C, which is even further out, but obviously must remain a consideration, is going back to some forms of lockdown as well. And that would be the most stringent. So going back to the Plan A then, and the 5 pillars, one of those 5 pillars we talked about is the vaccination programme. So the booster programme demand is very high. So the booster, as we know, and many of us will probably have gone for it, is most people, apart from the young, are getting jab 1, jab 2, and then the booster 6 months after the jab 2. Second bullet, 170,000. This is across Dorset as a whole. 170,000 booster doses delivered at a pretty good rate of 25,000 a week. At this point, I'm reading some people's minds. We know there've been some challenges, some pressures in booking booster jab, whether it be in walk-in clinic or whether it be through the GP route as well. And whether that's, I'm not here this evening to say, oh, it's that reason or that reason or that reason. It's a mixture of a few things which are being looked into. And especially with the Prime Minister's announcements now, it's got a certain urgency to get these issues resolved, most certainly. But 170,000 done, 45% of the eligible population, that is, across Dorset. So again, those doing the numbers, that's the over 40s plus the group of under 40s who are vulnerable in some way. So you come to 400,000 roughly, which is coincidentally the number in BCP, but it's 400,000 across the whole of Dorset. So if we continued that rate, about 8 to 10 to 12 more weeks, we'd have that population finished at that same rate. Okay. Due to high demand, there's low availability of walk-in clinic slots at the moment. So the last 2 points there, I won't read them word for word, but there's something there about, for the moment, persevere. The problems are being looked into. And also this last point, very importantly, trusted voices, vaccine ambassadors, for those who, for their own reasons, just prefer to stay, without the vaccine. Okay. If you go on to the next slide, please. Preparing for winter and different policy and regulatory environment now compared with last winter, to say the least. Okay, I covered the thing about the Plan B, which was the masks everywhere, working from home, vaccine passports, some much stronger messaging, not yet moving into that kind of status. We're putting together refreshed local outbreak management plans. There's a meeting this Wednesday involving the leader, the chief executive, and other relevant people, and I'm in the meeting as well, to work out exactly what we think we'll be doing, to do more detailed planning. And I think the rest of the points on here, and particularly what Sam and his team have been working very closely on and will continue to be. So when I hand over to Sam, I'll ask him to cover some of the points in this. I think the last thing before handing over to Sam is that we've had the announcements from government, from the Prime Minister and from the Secretary of State for Health. And if I can summarise those, what we've now got is the overlay of 18 to 40-year-olds who are now going to be offered the booster jab. And for the 12 to 15-year-olds, for whom the policy was just to have one jab, is to now offer them a second jab. This is for the 12 to 16s. The Secretary of State has suggested that what's called the COMF, the Contain Outbreak Management Fund, for which you may recall BCP received 3.5 million last year. That's going to be looked at again to see if there's any merit. Well, let me put it this way. It's going to be looked at, and we'll obviously be seeing what can be won, what can be gained from that fund if necessary. And I think Sam next is going to talk about preparing for winter. Let's talk winter and the package of measures that he and his team will be encouraging, coaching, assisting people with as we go into winter. So with that, if I may hand over to Sam at this point on the Let's Talk Winter, and if you can flick to the next slide, please. Sam, if I could bring you in here, please.
Thank you very much, Councillor, and good evening, committee members. So I think, as you can see from the presentation, we put this together a few days ago, and already we've been overtaken by events slightly, but the main points remain. As we go into winter, we're very, very mindful of the need to continue to work together as a group of public sector agencies. And one of the main planks in our intervention this winter is going to be an enhanced campaign, which is drawing on some of the real successes of the community-led work that we saw in the early stages of the pandemic, just to try to remind people of what they can do to look after each other, check on a neighbour, and above all, understand how you can best look after your own health and the health of those around you without putting too much strain on essential health and social care services. You can see from the first slide, although we've got many, many fewer people in hospital at the moment with COVID-19, it is still incredibly busy in the health and social care sector, as I'm sure you're all aware. So we need to do all that we can to take the pressure off. So this campaign has been produced by Public Health Dorset, Dorset CCG, working with comms leads in both councils, just to encourage people to look out for one another over the winter, think about others, check on your neighbours and relatives, and support our communities to stay well without having to resort to using those essential services. Next slide, please. So the key message is really about trying to encourage people to get together a plan for winter. So understanding what might need to be considered if you're going to look after yourself and your family, and just making it clear about those simple steps that you could take to help keep you as well as possible. Obviously, the immunisation campaigns are at the forefront of this campaign, so we're asking people to boost their immunity, whether that's through the COVID-19 booster, but also reminding people of the importance of the flu vaccine. We've started to see the first few cases, confirmed cases of flu in southwest England, so really, really important that people take up that opportunity to get their flu jab as well as the COVID jab. And I think the second point is opposite, isn't it? Because we're now talking about accelerating the booster campaign with the news of the new variant. But from a public health point of view, there are still those additional measures that are going to be really important through the winter period. So reminding people that those hygiene measures, remembering to test regularly, meeting outside if you can, avoiding enclosed spaces or spending too much time with people that you don't normally mix with, particularly if those rooms aren't ventilated. Those are all ways that we can slow or stop transmission, because when we're indoors in winter and we're mixing together, that's when the virus flourishes. So just a reminder of those additional public health measures that we can all take. And then some other top tips, if you like, about making sure that you've got your repeat prescriptions in plenty of time and your medicine cabinet's well stocked if you're a regular user of some of those over-the-counter remedies, making sure you've got a thermometer hand, and then understanding how you could help or support relatives or friends if you do need to seek out hospital care, and make sure that you've got the right things in place if people need to recover at home. Next slide, please. One of the main things we're encouraging people to do through this communications campaign is to plan ahead, get help early before conditions worsen, and there'll be repeated comms to encourage people to find the right route to seek that advice, speak to your GP, contact NHS 111, or indeed speak to your local pharmacist. And standard advice to avoid slips, trips and falls, taking extra care around the home. I've mentioned the point about keeping an eye on elderly or frail friends, neighbours or relatives, and the importance of heating your home effectively and safely. So as the temperatures drop, making sure that you've got a minimum indoor temperature of at least 18 degrees C, and trying to publicise some of those financial assistance routes if you're worried about paying for your heating. We'll be talking a bit about the 5 steps to wellbeing, remembering those 5 simple things that we can do to stay mentally and physically well, and above all, being kind and compassionate to those that we meet when we're out and about, and remember to support our staff. Many of our frontline professionals have been working in extremely difficult circumstances for an extended period of time, so just reminding people to please be kind when they're using those services. Next slide, please. So just a summary of some of the key issues and actions based on the other slides that we've run through tonight. Some of the measures that we're taking at the moment are supporting our schools to stay open, ensuring that children enjoy school safely. We have written again to schools this week to ask them to continue the additional measures to prevent the spread of COVID at least until Christmas. We're continuing to provide opportunities for people to take up lateral flow testing, and the national guidance is now emphasising the importance of taking a lateral flow test before you meet up or before you enter a high-risk situation. So if you're going to be meeting with friends or doing something that you don't normally do, make sure that you test to pick up any asymptomatic cases as quickly as possible. And we're continuing our local contact tracing partnerships under both councils. They will be extended until at least March 2022. Councillor Iyengar mentioned the Contain Outbreak Management Fund. We are in the process of agreeing how we will use that funding to continue to support contact tracing. And at the moment, there's a national conversation with government about whether we can extend the use of that funding beyond March 2022. We mentioned the Trusted Voices approach to promote uptake of the vaccination in our communities. That's going to be even more important over the next few months. And I've also just covered the Let's Talk Winter joint campaign with Dorset CCG. So those are the key issues and actions that we're taking this winter. Perhaps if it's helpful, I was just going to say just a couple of words about the Omicron variant, if that's okay, Chair. So it's a fast-moving situation. There are 5 confirmed cases currently in England. There are none in the southwest or locally that we know of to date. There are 6 further cases confirmed in Scotland. I'd probably expect this situation to change quite quickly over the next few days. We don't yet know enough about how responsive the variant will be to the vaccine, but I believe that the government are trying to collect as much data from some of the other countries in Southern Africa to try to investigate that as quickly as possible. We don't yet know the risk of serious disease or transmissibility of the new variant, but obviously as we get more and more data, that picture will become clearer. And I think it's just remains to be said, we will be working very, very closely with National Test and Trace. If there is any suspicion that we have possible or probable cases, the first response will be led by the National Test and Trace Service. But obviously we've been working very closely with them all the way through the pandemic, and we'll continue to update locally as we get more information. So I think that's all from me, Chair. I'll hand back to Councillor Iyengar and happy to take any questions.
Thank you, Sam, and that's all from me. So back to you, Chair. Thank you.
Thank you. Sam, could I just ask you to say a little bit about, I believe they've changed the way that you can go and get a lateral flow test now. It used to be very easy. You could just pop into a chemist and ask for some, didn't you? But they've changed that now. So I think they've made it not harder, but not as easy, let's say, you know. So I just wondered if you could explain a little bit about that and whether they might go back to just being able to go in and pick one up as when you think about it in the shops there.
Yes, thank you. So it's called the Pharmacy Collect scheme now, and you're quite right. You now need to scan a QR code, which should be displayed in all pharmacies. So you can still collect them from pharmacies, but they're asking you to book in, collect a code by scanning the QR code, which will be displayed on the poster. And I believe that's just so that they can keep a closer check on exactly how many kits are being handed out, because before there was no real information going back to the centre about how many kits were being handed out. You could literally just pick them up from the pharmacy. I believe you can still order them online as well. So if you're registered with the portal, you can still order your lateral flow tests online, but you do need to have a code in order to pick them up directly from the pharmacy now.
So are you saying then if someone hasn't got a smartphone that they're not going to be able to pick up a lateral flow test or can't go online, that perhaps they're going to have to get someone else to do it, because there'll be quite a number of people out there who are worried and they want to do these tests before they go anywhere, and it's making it very difficult for them.
Yes, and it's partly why we have a community testing programme still, which provides assisted testing to some of the groups that might not be able to access things like QR codes, because you're absolutely right. Lots and lots of these offers are now online or digital, which do require you to have a degree of digital literacy, or to have a smartphone or access to a computer. But we still have a community testing programme that provides opportunities to do assisted testing. They are from time to time in visible areas. We've had community testing in high footfall areas recently in BCP Council and Dorset Council areas. They do also attend some of the events, and they'll also be supporting things like the Winter Wonderland and Christmas shopping experiences over the next few weeks, particularly as it gets busy around Christmas.
Thank you. Any questions? Councillor Butler?
Yeah. I'd like to ask Sam information on the booster. Now, I've actually been offered a booster. I had 2 jabs, and then I've been offered a booster, but it might not be the same vaccine. And I'm a bit worried about this because they're not tested. And some people have had very bad side effects, and they've also had side effects to the flu jab. And the flu jab is also being given in short period of time between having that and the booster. So I'm just worried about the length of time between boosters and also the type of booster that we're being offered.
Yeah, thank you. So the current advice from the JCVI is that you can give a 3rd dose using a different vaccine to the first 2 doses that most people would have had. So in some instances that might actually offer additional protection because the vaccines are all slightly different. But there's no reason to worry if the 3rd dose is different to the first 2 doses that you received. That's all been approved by the Joint Committee on Vaccination and Immunisation. In terms of some of the side effects, obviously some people do feel differently when they've had either flu vaccine or COVID vaccines, and you can have quite a variable response to them. Some people do develop a bit of a fever or might feel a bit off having had their vaccine. But I would say that's not the sort of thing that you would normally report as a side effect. It's one of those sort of transient and temporary effects that you might feel once you've had the vaccination, and it's partly because your immune system is kicking in and starting to respond to the vaccine.
Can I just come back on that and say that if your body is trying to fight off something, usually you wouldn't have another introduction of a vaccine on top of what you've already had. This is unprecedented. This is the worry, and most drugs are tested for a lot longer than this one has been. That's what people are worried about, I think.
So I'm not aware of any sort of firm evidence from the safety data that what's being recommended through the JCVI is leading to additional problems. If your query is about the dual delivery of the flu vaccine and the COVID vaccine at the same time or during a similar window, there have been trials that have been carried out that have shown that it's safe to deliver both of those vaccines together.
Councillor Farr.
A quick question, if I may. Do we know at this stage how the new variant compares to the existing strains? Is it more or less life-threatening? And sort of following into that, secondly, do we know how effective the booster is likely to be in shielding against the new variant, considering it is new? Yeah. Thank you.
Yeah, thank you. I think it's just too early to tell at the moment. So as I sort of said in my brief introduction to it, the UK Health Security Agency are trying to gather as much data as possible from international countries as well where they've had more cases of the variant. But so far, it's too early to be able to say with any certainty how this new variant compares to the current Delta variant, which is the one that's dominant in our population. But they are very, very alert to the possibility that it may be more resistant and evade the vaccines that we currently have. That's what they're anxious to find out about. But at the moment, it's too early to tell. We don't have enough data, and that's what UK Health Security Agency will be assessing as quickly as possible over the next few weeks.
Thank you.
Councillor Robson.
Thanks, Chair. Sam, with a lot of people now knowing probably in excess of 5, people in their own circle who have had COVID, when do we stop worrying about infection rates and just concentrate on hospital rates and recovery rates? And I appreciate that it's early days, but you alluded to that the flu rates are starting to come in now. When do we start comparing COVID with flu hospitalisations and come to a point where actually we're now living with this as just another coronavirus that we have to deal with on a yearly basis?
It's a really good question. I think if I was talking to you last week, my answer might have been slightly different, and that I think all of us were starting to accept that this is becoming a seasonal winter virus. It's going to get worse in the winter periods, and to some extent, because we have vaccines, we do have to accept a certain level of infection in the community and learn to live with it. And the big difference, of course, now is that hospitalisations are much, much less than they were. If you compare back to the wave that we had in January 2021, we've got many, many fewer people in hospital with serious disease. But one of the issues connected with ongoing transmission is that it does allow the virus the chance to mutate. And so when we do have these new variants that crop up from time to time, that's what worries the scientists a bit, that they need to assess just how much of a threat these new variants may pose. And obviously, the more chances you have for viruses to replicate, the greater the chance you will have of some of those mutations turning out to be, a bit more worrying than just the standard mutations that accumulate in a virus. So I think we don't yet know enough about the Omicron variant. I'm hoping that over the course of the next few weeks, it'll turn out to be no more than a concern that we should be vigilant for and not a serious threat. But we've been here before, and you can see just how quickly some of these new variants can become the dominant strain of virus in the population. And when the last time this happened, when we had the Delta variant, it took over very, very quickly. And of course, although it didn't result in more serious disease, it was much more transmissible than the previous variant, Alpha, which was dominant in our population. So I do agree, we do have to be pragmatic about this and learn to live with the virus. I don't think it's all about the vaccination programme. Vaccines are a very, very important addition to our arsenal, but at times, particularly in the winter, when we have high levels of circulating infection, my advice as Director of Public Health is to remember those other public health measures that can be useful and helpful in reducing the chance of transmission. So going back to some of those basic measures of wearing masks when we're mixing with others in enclosed spaces, remembering to ventilate spaces properly, remembering the importance of hygiene, and also keeping a distance. So I think some of these measures are going to be with us for some time to come. And of course, they're much more important in winter when many of us are more likely to be indoors and mixing.
Yeah, great. Thanks, Sam. Great answer. And I was a bit concerned earlier today when I heard a medical expert say that if we hit this now, it'll all be done by June next year, which as a layman, I thought was just a rather incredible thing to say, because I don't believe that at all. But thanks for the answer. Great answer. Thanks.
Okay, thank you.
Councillor Butler.
Yeah, can I just ask? We've had the treatment of helping people, the advice that you've been talking about with the Let's Talk Winter. BCP had the Together We Can scheme, which worked really well. How do these two work together? Do we still carry on the Together We Can? Because some volunteers weren't even used last time. So if people are quite happy to keep on volunteering, is that going to happen, or is this other one going to take over from it?
Yeah, thank you. It's a really good question, actually. So it's important to realise the campaign I've talked about tonight is predominantly a joined up communications campaign, but on the ground, those messages are being given to many of the groups that we've been working with all the way through the pandemic. So there's a range of materials that are being produced that community organisations can use. You can have some of those key messages printed up and displayed for use in different settings. So the campaign concept provides the artwork and the key messages, but it can be adapted by lots of the local groups that we've been working with all along. So the importance of volunteering, I think it's still going to be crucial over the winter period. If there are still people supporting responses like Together We Can, that's a really effective thing that we need to keep going, because that support's vital in making sure that we've got people on the ground who are able to check on neighbours and to keep them well. So don't think of it as a replacement. It's an addition to some of those efforts that are already going on in our communities.
Thank you.
Sam, can I just ask you about the difficulties of actually booking your COVID booster? Take me, for example. I've been told that I should book it now. So I've put in my postcode and everything, and I've been given Boots in Bournemouth for one day, which is completely full. And the next one is Salisbury or Southampton. But I haven't got time to trot over to Salisbury or Southampton. So I'm thinking, this is on the NHS site, there must be more local ones that I could book into. So do you know if they're going to, if the government's announced, you know, more people to get the booster, they're going to have to open up more centres for people to go in and get them. And do you know they are going to be opening more places? I mean, obviously, the BIC was a great place because they could do such a huge number all at one time. And we're now sort of placing a lot of, you know, stress on the pharmacies trying to get everybody through. So I was just a question whether we're going to open up more centres.
Yeah, again, it's a really good question. I think there's several things going on. So undoubtedly, the national offers that have come out over the last few weeks have put the stress on the local system. And our limit at the moment is the number of trained vaccinators working through different settings that we have to deliver the booster programme, along with the other offers, including the second dose for 16 and 17-year-olds and the 12 to 15. So I mean, I'm not responsible for delivery of the vaccination programme, but obviously I do work very, very closely with Dorset CCG and other colleagues through the vaccine delivery cell. Over the next few weeks, we're going to have to be thinking very carefully about how we can be a bit more creative at bringing on additional capacity, because it's not just about the number of sites. Even if we could identify more sites, to staff those sites safely and to have the required number of not just vaccinators, but also trained staff to run those sites is one of the limiting steps at the moment. I think the advice locally for many people, because I understand that if you're using the national booking service to try to get a slot and to book a walk-in slot is very, very difficult because there's a high demand at the moment. The other thing to bear in mind is that primary care is working through the lists as quickly as possible. So the other way that you may be called is by being contacted by your GP practice or by the primary care network that's delivering the vaccination programme on behalf of your GP practice. So look out for when the NHS also calls you for your booster programme. And actually, if you wait for the primary care offer, that's a more equitable offer because it doesn't rely on people having the ability to continually refresh the national booking site, for example. So they will get to people, but it might take a bit of time over the next few weeks as we go through this pinch point of a huge number of people becoming eligible. But we are doing everything that we can locally to try to get people those boosters as quickly as possible.
Thank you. Councillor Robson.
Yes, and just a follow-on point. I've had the same frustrations of trying to book a booster about 4 times now and almost given up on it. What slightly saddens me is when I went for my second a flu jab, I was about 2 weeks off my eligibility for the booster. They had everything there, but the computer said no, so I wasn't given it. Is there any? I'm sure my body wouldn't care whether I was 2 weeks out on my booster jab. Is there any scope for bringing that more in line?
So I think the government's announced today that they're going to look at cutting the interval for boosters from 6 months to 3 months. So that announcement was made via JCVI, and I believe the government's endorsed that today. So you should see more flexibility about bringing those timescales down and being able to, perhaps we can be a bit more flexible and creative with making sure that some of those offers align.
Thank you. Anybody else got a question? Sam? Or Councillor Iyengar? No? Okay. Thank you very much. Can we move on now to our forward plan? And please read the dates as 2022, not 2021. Could I also just quickly say, I hope you all managed to catch the Budget Cafe and the Adult Social Care presentation by David and Phil there, which was absolutely excellent. If you haven't seen it, try and catch up on, is it on YouTube? Do we know, Joe? It's everything you wanted to know about what we spend the budget on and how they get the money. It was very good, thank you. If we move on to our forward plan, I think there's a couple of things to actually add to this. One of them is the All Age Autism Review project. I think it was a Dorset business case. I think we need to add that to our forward plan. And I think Children's Services will be adding that to theirs as well, their sort of section of it. So has anybody got any questions on the forward plan? I noted on our action points, actually, we have the hospital infrastructure plan. I think that just needs to go onto our forward plan, sort of when we know a bit more about what's happening with the building works and everything that's going on, and when the pool have their new theatres built, etc. So we'll have a review on that maybe later in next year. I think, David, did you mention we needed to put front door survey on forward plan?
The front door service chair did undertake a survey of client satisfaction, but got a very low response rate. It may have been connected with the COVID pandemic at the time. So Tim Branson, who we heard from earlier, is supplementing that with some additional survey questions. We're trying to reach more clients. We have offered to circulate the revised feedback from that as soon as Tim's collated it to this committee. So I'd be very happy to make that arrangement. Of course, if you wish to, Chair, you could invite Tim to present that personally to the committee.
What does the committee think? Do you want to have it circulated to you and to ask any questions, or do you want a presentation? Oh, are you all frozen to death here? Circulated, right? Okay, thank you, David. I think also we may possibly get for January the birthing clinic that's been delayed quite a few sort of sessions, isn't it? Yeah. So anybody got any questions on the forward plan? No? No? Any other questions about anything? No? Okay then, let's close the meeting. Thank you very much.